You're in the operating room. The surgeon needs a perfect, unobstructed view of the airway, but you, the anesthetist, have the absolute duty to keep that patient breathing safely. It's this classic tug-of-war over a shared, critical space. So the big question is, how on earth do you ventilate a patient when there's no room for an endotracheal tube? Well, that's exactly where a technique like jet ventilation comes into play.
Welcome. If you're prepping for your anesthesia exams, then you are in the right place. We're about to do a deep dive into jet ventilation. Our goal here is to take this pretty complex topic and boil it down into a clear, high-yield review that's going to give you exactly what you need to know, all based on a fantastic article from BJA Education.
All right, here's our game plan. We'll kick things off with the absolute basics, the core principles and variables you have to know. Then we'll get into the different types and how we deliver them. From there, we'll talk about the clinical side, when to use it and how to tweak it. And we'll wrap up with what is, without a doubt, the most important part, keeping your patient safe. Ready? Let's get into it. Okay, first things first, let's build a solid foundation. Before you can understand the fancy stuff, you've got to have a rock-solid grasp of what jet ventilation actually is, and the 4 levers you can pull to control it. Now, I want you to focus on 2 words here, high pressure and open airway. That's the whole magic trick. We're not using a cuffed tube to create a closed system like we normally do. Instead, we're literally firing a high-pressure jet of gas into an airway that's open to the room. And right there, in that simple definition, lies the secret to both its incredible utility and its biggest dangers. For your exams, this slide is everything. Seriously, everything you do with jet ventilation boils down to controlling these 4 variables. You've got your frequency, how many puffs of gas per minute. You've got the driving pressure, basically how hard you're pushing that gas. Then there's the inspiratory time, how long each puff lasts. And finally, the gas composition, what's in the mix, mainly how much oxygen. If you can explain these 4, you're well on your way.
Okay, so now that we have the basic principles down, let's look at how they're actually put into practice. We're going to talk about the different flavors of jet ventilation and the ways we can get that jet of gas to the patient.
So you can think of jet ventilation as having 2 main families. On one side, you've got low frequency, or LFJV. This feels kind of familiar. It's at a normal breathing rate, maybe 12 jets a minute, and each jet delivers a decent-sized tidal volume, enough to wash out the dead space. You can even do it with a manual device. But then, you've got high frequency, or HFJV, and this is where things get weird. We're talking crazy fast rates, sometimes thousands of jets a minute. And here's the paradox you need to remember. The tidal volumes are tiny, often smaller than the anatomical dead space, and yet it works.
So if low frequency is good at getting rid of CO2 and high frequency is great for oxygenation, what if you did both at the same time? Well, that's the genius of superimposed high-frequency jet ventilation, or SHFJV. You're basically running a constant background of tiny, high-frequency jets to keep the lungs open and full of oxygen, and then, every few seconds, you fire a bigger, low-frequency jet over the top to provide that bulk flow you need to clear out the CO2. It's a really elegant solution.
And here's what that looks like on a modern ventilator. This is the screen of a twin-stream machine. You can literally see the 2 systems side by side. The controls on the white side let you set up your low-frequency, normal jet for CO2 removal. And the controls on the green side are for your high-frequency jet for oxygenation. It gives you incredible control to fine-tune both things at once.
So how in the world does high-frequency ventilation work with those tiny tidal volumes? Well, the truth is it's not one simple thing. It's a whole mix of complex physics. You've got gas streaming down the center of the airways in a smooth flow. You've got gas mixing and dispersing in strange ways. You have gas shuffling between different parts of the lung. Even the patient's own heartbeat helps mix things up. The key takeaway for you is that gas exchange is happening through a bunch of different mechanisms, not just the simple in and out flow we're used to.
Right, so we know what jet ventilation is and how it works. Now, where do we deliver it from? There are really 3 main options. You can go supraglottic, where the jet comes from a device above the vocal cords, often part of the surgeon's laryngoscope. You can go subglottic, with a special catheter that you pass down through the cords. Or, in more urgent situations, you can go transtracheal, right through the skin of the neck into the trachea.
Now, this is a really important comparison. With the supraglottic jet, the high-speed gas acts like a vacuum, sucking in or entraining a ton of room air. This boosts your tidal volume, sure, but it also means you have no idea what the final oxygen concentration is. It's also riskier for trapping gas. A subglottic catheter, on the other hand, doesn't really entrain air, which gives you more control,
But, and this is a huge but, any blockage to gas getting out becomes a massive problem. The real game changer for subglottic, though, is that you can monitor pressure and sample gas right at the tip, which is a huge safety feature.
And here's the piece of kit that makes it possible. This is a double-lumen jet catheter. See those two ports at the end? The blue one is where you hook up the high-pressure gas line to actually do the ventilating, but the red one is your lifeline. That's connected to a second, smaller lumen that runs all the way to the tip, letting you constantly measure pressure and check your end-tidal CO2. It's this kind of smart design that has made the technique much, much safer.
All right, let's shift gears from the how to the when and why. We're moving into the practical stuff now. When would you actually reach for this technique? And once you're using it, how do you dial in the settings to get the result you want?
So the number one reason, the classic indication, is obviously airway surgery. It gives the surgeon an amazing tube-free feel to work in. But it's so much more versatile than that. It can be a literal lifesaver and a can't intubate, can't oxygenate emergency. It's used in thoracic cases with leaky airways, and it can even be used to create an almost perfectly still operating field for super delicate procedures like ablating tumors or cardiac arrhythmias.
Okay, this table is pure gold for your exams. It maps out how to adjust your settings. But look closely. It's a balancing act. For example, to get rid of more CO2, you might crank up the driving pressure. That also helps with oxygenation, which is great. But if you increase the inspiratory time to help oxygenation, you might actually make your CO2 retention worse because you're leaving less time for exhalation. The lesson here is that every change you make can have downstream effects, so you have to constantly monitor and adjust.
And now we've arrived at what is hands down the most critical part of this entire discussion. Knowing how to use jet ventilation is one thing. Knowing how to use it safely, that is everything. Understanding the dangers is absolutely non-negotiable.
So when should you think twice, or maybe not even do it at all? The number one red flag is a major obstruction in the airway. Just think about it. If you're forcing high-pressure gas in, but there's no easy way for it to get out, you are setting the patient up for an absolute catastrophe. The same goes for significant airway trauma, or if there's a foreign body you might just push deeper into the lungs.
If you remember one thing from this whole explainer, let it be this quote. It's pulled directly from the source article, and it is the central safety message. Barotrauma, that's lung injury from too much pressure, has to be the thing you are constantly, actively thinking about and trying to prevent, from the second you start to the second you stop.
And this is exactly why that warning is so important. When barotrauma happens, it's bad. We're talking collapsed lungs, air trapped in the chest cavity, and patients becoming dangerously unstable. And that's not all. You've got the risk of an airway fire if there's a laser involved, getting blood or debris into the lungs, and even, in very rare cases, rupturing the stomach. These are the things that keep us up at night. So, what can we do to make this whole process safer? Well, a huge piece of the puzzle is the anesthetic itself. Remember, it's an open airway. You can't use your normal anesthetic gases because they would just float out into the room. So the standard of care is total intravenous anesthesia, TIVA, along with a deep muscle relaxant. That paralysis is crucial to stop the patient from coughing or bucking, which could suddenly block the outflow of gas.
And this is maybe the ultimate safety rule in all of anesthesia, and it applies here more than ever. You must always plan for failure. Assume at any moment the technique could stop working. That means before you even start, you have your backup plan ready to go, your face masks, your LMAs, your intubation kit, all checked, all right there within arm's reach.
So we've gone through the theory, the equipment, the uses, and the massive risks. You have the knowledge now. But the real test, the question I want to leave you with is this. When you're the one in that room, standing at the head of the bed with the airway shared, how are you going to take all this theory and turn it into safe practice for your patient?
This whole explanator was based on the article Jet Ventilation, published in BJ Education. If you really want to cement this knowledge, I absolutely recommend you go and read the full paper. Thank you so much for joining me.